like to thank you all for being here. My name is Michael W. Belin. I'm a professor of ophthalmology at University of Arizona. I'm also a consultant to Oculus and chief medical officer of Epion Therapeutics. What I'm going to be talking about today is a little introduction of the soon-to-be released version 4 of the bad display. So what I'm going to be talking about is the good, the bad, and actually the future. So what's new in version 4? Well, one simple change is there'll be a name change. In the past, it was called the Belin Ambrosia Enhanced Ectasia Display. It's going to be simplified to just the Belin Ambrosia display. Now, there's a reason for that more than just making it an easier name. And that is, in the past, there was a misconception that the bad display was specific for keratoconus. It is not. Now, I'll show you later how we utilize it to detect keratoconus and how to diagnose keratoconus, but the display itself was initially designed for refractive screening to separate normal from abnormal. So again, it's different to have something that specifically diagnoses keratoconus or something that separates normal from abnormal. These are some examples of abnormal bad displays. The one on your bottom left is post-refractive. If you look at the first column, that's the anterior elevation, you'll notice this flattening, and that's what you'd expect if we flatten the cornea. The second column is the posterior elevation. It's very normal because we don't expect to see changes on the posterior surface after refractive surgery. You'll notice that the upper right is a pachymetric map. It shows a thin cornea because we've ablated the cornea. And if we look at the pachymetric progression graphs, they're slightly abnormal. So this is not a normal cornea. It doesn't mean it's keratoconus. The upper right can look like keratoconus. It's a hyperopic LASIK. You'll notice the anterior surface shows steepening of the anterior surface, normal posterior surface, but again, not a normal cornea, but not keratoconus. And the lower right is endothelial decompensation. You'll notice, if you look at the PTI graph, you notice that it's very flat. In other words, we no longer have the normal transition from a somewhat thin central cornea to a thicker periphery because we've lost that normal pachymetric progression because we have corneal thickening due to endothelial decompensation. Now, all these are abnormal. None of them are keratoconic. But while I've said that, I mentioned I'm Chief Medical Officer of Epion. We are in the middle of a phase 3 study for epithelium-on keratoconus treatment with cross-linking. But we utilize the bad display as our major entrance criteria. But I just said it's not specific for keratoconus. So if you look at our inclusion criteria, we require a final D of 4 or greater. But to make it specific for keratoconus, we also require a posterior elevation at the thinnest point of 13 microns or greater. And we require a percent thickness increase tracing at midline or lower. So again, we add things to make the abnormal D much more specific for keratoconus. So again, the final D gives you variation from normal, not specific for keratoconus, but when you add the additional parameters of posterior elevation at the thinnest point above 13 microns and a PTI tracing at midline or below, we now take what was not necessarily specific for keratoconus and make it very specific. So this slide shows the progression of the bad display. So the bad display was initially introduced, and I may have been off by a year or two here, in 2008. And if you look at the one on the left, it shows you, again, the anterior elevation, the posterior elevation, the pachymetric progression, but you'll notice that there are no additional parameters and no an actual final D. So the initial bad display really didn't use any, and we'll use the term artificial intelligence. In other words, it didn't interpret the display. The second iteration, released in 2010, introduced 5 parameters. Those 5 parameters, and unfortunately, the pointer, I don't think my pointer will show up on the screen. It doesn't. 5 parameters that show on the bottom of the display, and they were utilized in a regression analysis to give you an overall reading of how normal or abnormal that map was. 2012, which is the version most of you are using now, version 3, added some additional parameters. It went from 5 parameters to 9 parameters. There were a number of other changes going from version 2 to version 3. So first, if we look at the area under the curve, the AUROC curve, this is comparing version 2 to version 3. Now, it doesn't look very impressive, not a whole lot of change. But when you get up to that level, changing little increments are actually monumental changes. So imagine if you had something that only occurred in 1 in a million, and you change it to 1 in 2 million. That's a huge improvement, even though if you graphically showed that, it wouldn't look like a huge change. So what were the improvements made to version 3? First, we added 4 additional parameters. We added elevation at the thinnest point for the anterior surface, elevation at the thinnest point for the posterior surface. We added ART max, another pachymetric progression parameter, and we added K max. So to the original 5 parameters, now we added these 4. We also added a hyperopic database so that you would check off whenever your patient was hyperopic in any meridian. So it's really mixed CIL or pure hyperopia. We also added drop-down parameters. You'll notice these little yellow triangles throughout the display. If you click on those, you get an explanation of what that parameter is. And we gave you an option to turn off the color coding, and I'll go over that later. But you can never turn off the color coding of the final D, which is the overall reading. Now, only parameters that improve the overall performance were added. So we went from 5 to 9 parameters. Well, that's almost true, okay? Kmax is a horrible performing parameter. All you out there wanted us to incorporate Kmax because it's so commonly used. But it really, as you can see here, for those of you who are familiar looking at these curves, it's really a very poor performing parameter and actually did not add anything to the overall performance of the map, but people wanted it, so we listened to the people. So this is the current version of BAD 3, and I'll try to go over it with you without a pointer. But again, the first column on your left is anterior elevation. The upper one is the standard anterior elevation against a best fit sphere taken from a 8mm optical zone. The middle one is what we call the enhanced reference display. Instead of using an 8mm optical zone, we use that 8mm optical zone, but we remove what we call an area between 3 to 4 millimeters centered on the thinnest point. That 3 to 4 millimeter exclusion zone is proprietary to the BAD. So you'll see a lot of companies, and I'll address this later, will try to mimic the display, but they use a fixed exclusion zone, which won't give you the same results. The map, the display on the bottom, and I hate, it's not a map, it's the numerical difference going from the standard display to the enhanced display. And that is highly specific for separating normal to abnormal, or in this case, normal to ectatic disease. The second column represents the same thing, but it's the posterior elevation. So the first one is the posterior elevation. again, against the standard 8mm optical zone. The second one is the enhanced reference surface, again, removing that exclusion zone. And the bottom one represents, again, the numerical change. You'll notice as we go to the right, to the far right, that's the pachymetric map. And if we go to the bottom right, those are the two pachymetric progression graphs. What you'll notice going from version 2 to version 3, and I wish my pointer worked, we've added that box over here, the elevation at the thinnest point, both anterior and posterior, which were not present on version 2. So I say here, version 3 has 9 parameters in a regression analysis. Each of these 9 parameters are reported as standard deviations. It'll change to yellow at 1.6 standard deviations, and it'll change to red at 2.6 standard deviations. Okay? There are other parameters not used in the regression analysis, but they are also reported as standard deviations. The final D is an overall reading based on a proprietary regression analysis. It is not an average of all the parameters. Okay? It is also, and this is very important, it is not a standard deviation. Okay? People understand, people are confused because it's reported as a number also. It is a deviation from normal, but not a standard deviation. And it's yellow at 1.6 and red at 3.0. Okay, and that's a proprietary scale. So that brings us to 4. Okay, so version 4 is soon to be released. So what's new in bad version 4? First, the database has been increased to almost 4,000 eyes from 26 different international sites. It utilizes what we call an optimized logistic regression algorithm. You can consider it refined AI. What's important, you may read a lot of literature and you'll see terms of a random forest index. That's another way to interpret the data. The problem with a random forest index, it requires actually a change in the user interface. What we found is that using a logistic regression analysis, the overall performance was equal to the random forest index without having to change the end user experience, which is critical. You can imagine if you went into your car one day and all the controls were changed, that's a major problem for you. So we were able to improve the overall function and both specificity and sensitivity while keeping the end user interface the same. In version 4, we'll again have improved diagnostic accuracy. Okay. In that optimized logistic regression analysis, we looked at 120 different parameters. As I said, we only utilized those that actually improve overall performance, and only 11 ended up being utilized in the regression analysis. So again, version 1 had 0, version 2 had 5, version 3 had 9, and now this is 11. More did not improve overall performance. Okay. And I always go back to way back many, many decades ago when Placido systems first came out and they were automated, and we had different companies kept telling you, well, we have 20,000 points in our Placido, we have 100,000 points, but that was somewhat meaningless because the weakest link was not the number of points to put on a single circle, it's how many circles there are. Okay, so you can imagine I could have had a Placido of 1 circle and put 1,000,000 dots on it, it would be highly inaccurate, even though I have 1,000,000 data points. So a chain is only as strong as the weakest link, and we only needed to utilize 11 parameters. Anything more really did not help. And the parameters actually are very different. These are the 11 parameters utilized in version 4. And the one I'm going to highlight, only because it's been something I've done clinically myself, is age. age was not a parameter utilized in the earlier versions. But when I've lectured, I've always said, in my clinical practice, I've always adjusted based on age. And I don't want you to look at this because you don't have to pay attention to it anymore, because version 4 will do this for you, but there is an age adjustment. And in my clinical practice, the younger you are, I would actually add. So in other words, I would add to the final D. The older you are, I would subtract. And when I actually did this and tested it against the TBI, I don't know if you know what the TBI is, it's a tomographic biomechanic index, which had an age parameter built into it. It turned out my clinical age adjustment followed the TBI age adjustment almost identical. But so the new version 4 will incorporate age as a parameter. So again, I already alluded somewhat to this. The random forest index versus simpler logistic regression analysis. The random forest index is more complex, but it gave similar results to our easier logistic regression analysis and equal AUROC curves. Again, the main advantage of using the simpler logistic regression analysis is it kept the same user interface without the expense of accuracy. So what's new in the bad version 4? So any prior exam that you did, once you upload, and it's not yet released, once you upload version 4, your old exams will still show you the final D based on the version 3. And you can see here it's circled. It'll have a little parentheses that says V3. The reason for that is we don't want, for medical legal reasons, we don't want an old exam that you thought was normal suddenly looks different. Truthfully, there's going to be very little change, but we want to make sure you keep your old parameters. So again, if your old exams will come up and it'll say version 3 on them. Okay. Many of you may not know this, but there's a drop-down menu again that lists all the literature supporting it, and there's a recent publication that's on the bottom that will now support the version 4. So what's the change in the performance? That's really what you want to know. Why are we coming out with a version 4? Okay. So if you look at this table on the left, this compares version 3 to the soon released version 4, separating normal from known keratoconus. Okay? So again, I want to say this is known keratoconic corneas versus normal. You'll see that the performance is just excellent and the change is very small. The area under the curve for version 3 was 0.994, and here it improves in version 4 to 0.997. Now, these seem inconsequential to you, okay? And to the individual user or to the individual patient, it may seem inconsequential, but I'm going to give you an analogy. Okay, we were talking earlier about planes taking off, and there's 100,000 planes that take off every day in the world. I didn't know it was that number, okay? Now, imagine if there was one crash a week, okay? So that's about 1 in 700,000, okay? To the individual person boarding a plane, if they're told, you know what, you have a 1 in 7,000 chance of a problem, that's infinitesimally small. But to the aviation industry, if I'm able to reduce that in half, that's a major advantage. So for the individual doctor, individual patient, but take refractive surgery as a whole, if you're able to reduce the amount of post-LASIK ectasia in half, or in this case, even by 2/3, that's a major, major improvement. Even though if you look at the individual patient, it's inconsequential. So, but if we look at the table on the right, now we're comparing normal to what we call, and I'll use the word suspicious. So these are eyes that were known to have keratoconus in one eye, but had a topography, not a tomography, topography that was normal in the other eye. Okay? And here you'll notice a much greater improvement. We went from an AURC in version 3 of 952 all the way up to 974. So that is a very large improvement. So why is this important? Because these are the cases that are most confusing to the end user. So again, the greatest improvement is in the most difficult cases, the cases that may have normal topography but represent very early disease. Okay. Now, the other thing to be aware is that, and I believe this is being changed, but the current version 4 does not have a hyperopic or mixed-cell database. So when you choose hyperopic or mixed-cell in the bad version 4, it will utilize version 3 software. I'm told that's being addressed, but that's current. This will be seamless. You won't have, as end user, again, there's nothing you need to do. And as I said, I'm being told it will be addressed in a future update of the version 4 software. Okay. So let me take a drink. As the end user, what changes will you notice when going from the bad version 3 to version 4? Nothing. Well, that's partly true. That's really the goal, and that's, again, why we utilize an optimized logistic regression analysis. Because, as I said, I used the example of the car before. We want you to get in the car, and the controls are the controls you're used to. Okay, just the performance is better. It's like, I don't know if we have any car people in the audience. It's like you did an ECU upgrade on your car. Everything looks the same, it just performs better. Okay. So again, as I said, the overall performance will be improved, but the end user experience will be very similar. So I want to go over a couple of questions I often get about the display in general. So I think we were talking about this earlier. First frequent question, how do I interpret the bad if I can't get a full 8 millimeters coverage? Okay, and full coverage may be difficult or sometimes even common in abnormal corneas like advanced keratoconus, in elderly patients with lid laxity, in Asian population with individuals with smaller eyelids, and in poorly cooperative patients. So how do I determine keratoconus progression if I can't get a full 8 millimeters of coverage? If one day I get 7.6 millimeters of coverage, they come back 3 months later and I get 7.7, and at the 6-month exam I get 7.2. Each exam has a different area of coverage, which means my reference surface for every exam is going to be different. And this is not an uncommon thing with keratoconus. This is one of the reasons we developed the progression display. The progression display utilizes a 3 millimeter optical zone centered on the thinnest point. And it shows you both the anterior, posterior, and minimal corneal thickness. It does not require a full 8 millimeters of coverage. Your progression display is relatively insensitive to coverage. And that's one of the major advantages to actually utilizing the progression display to determine whether your keratoconus patient is stable or progressing. So how do I interpret the bad if I can't get 8 millimeters of coverage for general screening? Most of the time, you're going to be able to look at the bad and know whether it's normal or not. But I've gotten some queries where the coverage was so small, okay, that the data on the left side is just not reliable. Always look at the PTI tracing, okay? The PTI tracing is always going to be accurate up to the area of coverage. So even though I may not be able to interpret the left side here, if you look at the PTI tracing, it is abnormal right from the beginning. This is an abnormal map. Now it's abnormal, I can tell it's abnormal, but sometimes it could be so irregular looking, and if the coverage is so poor, but if you look at the PTI tracing and it starts off going down below, it's an abnormal map. Finally, how do I compare exams with different total coverage? Very similar to what we discussed earlier with the progression display. If I get different coverage each exam, then my best fit sphere, which is not going to be 8 millimeters, will vary exam from exam. So you can use the compare to exams. But what you'll notice right now on the compare to exams, that here I got to show you, you'll notice the best fit sphere in this exam is 7.54, and here it's 5.46. That would be like asking someone which building is taller. Well, one is being measured ground level and one is being measured at the basement, at bottom. The references are different. So there is, if you click right over here, you'll get a drop-down menu, okay? And you'll notice it says here, change reference all exams. It makes all the reference surfaces equal, so you can do a comparison over time. I'll be honest with you, the progression display is a hell of a lot easier to look at than doing this. But if you want to do it, you can do it. The advantage of this is you can choose almost any display to compare. You can do elevation, you can do curvature, you can corneal thickness. So that's okay. Now, in closing, I just want to say there have been multiple other proposed screening displays and programs. None have really gained significant market penetration. There's also been a number of what I will call copycat displays. Most of these, I think, on some Asian manufacturers. And here's one. I do want to say that you'll notice on the far right here, it's the Belin ABCD staging. That is an open access program. It's something we allow any company to utilize, partly because if you're going to have a staging system, a classification, it has to be ubiquitous. But what you'll notice on this copycat bad display, you'll notice it says exclusion 3 millimeters. That is not what the bad is. The bad is a proprietary 3 to 4 millimeter based on a number of internal parameters. And you'll also notice that there is no final D. So
the panting, the moaning, the screaming.
Fake, 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 fake.
So again, the bad has been often imitated, but really not duplicated. Again, there's been a number of others, I said, that haven't really gained market support. It's also very difficult to do comparative testing. Most papers, when you read them, what they're really doing is they're testing their own definitions. They'll define keratoconus by A, B, and C, and even though they say we have a test and a retest, their retest is still using their own defined definition of keratoconus. So you'll see comparisons between the bad and some other, and you really can't do that. So the only real test ultimately that really matters is the test of time. And the bad display is definitely the most commonly used refractive screening program and really has been since 2008. Thank you.